All right, so let's talk about the integumentary and start with pigmentation. So the main molecule that gives skin its color and hair its color and your eyes their color is a pigment protein known as melanin. Melanin is made by your melanocytes, and so you can see our melanocyte here. Making the melanin is a protein, remember, with our protein synthesis coded for in the nucleus, then proteins made in the rough endoplasmic reticulum, processed in the Golgi, and then sent out in vesicles to where they're released via exocytosis into the surrounding keratinocytes. And so, especially when you have sun exposure, you're going to get accumulation of the melanin on the sunny side of the nucleus to protect it. And so they produce the melanin in that basal layer of the epidermis. It is composed of an amino acid, tyrosine, chemically bonded, and there is a enzyme, tyrosinase. Remember, anything with ASE is our enzyme acting on tyrosine. That's why it's called tyrosinase. And it gets deposited through that special vesicle known as a melanosome. Here you can see that the different pigmentations and the different colorations of skin. So we all have the exact same number of melanocytes. So our melanocytes are virtually identical among all individuals respective of skin color. What is different is the amount of tyrosinase. Remember, that's the enzyme we just talked about that cleaves the tyrosine, and the type of color the melanin produced. And so here you can see a photomicrograph of Caucasian, Asian, and black skin, and how the differences in melanin content is in each of those. And that was a publication by the NIH. And as I mentioned before, melanin also plays a role in vitamin D synthesis. And so being exposed to the sun helps to manufacture vitamin D after the skin absorbs the sunlight. It is then carried to the liver, where it is converted into calcidiol, which is the primary form of vitamin D circulating, or is taken to the livers and is transformed into calcitrol. And that is a biologically active form of vitamin D. So we all need a little bit of sun exposure to make the vitamin D that we need. And what vitamin D does is help with calcium ion absorption. Other pigments that can contribute to skin color are carotene, and this is a yellow-orange pigment found in things like carrots, pumpkins, sweet potatoes, and you can actually get too much of that. Here is a carotenemia, so it can turn your skin kind of an orange color. You can see it in infants sometimes. A lot of times you're going to need a mutation in the enzyme because the carotene is actually further converted into retinol, vitamin A. And this is you have to do it for a long time and a lot, over multiple months before it really starts depositing. And this is a 24-year-old female with carotenemia of the palms, and she did that because she consumed way too many V8 splashes. Another pigment that also contributes to skin color is hemoglobin, and that is found in our red blood cells. It transports oxygen, and you can see it when you exercise. When you get flushed and warm, your face gets red and your skin will sometimes get red, and the paler you are, the more you're going to see the contribution of hemoglobin to your skin color. This is a publication about the relationship between physical properties of skin, showing the coloration as hemoglobin increases and as melanin increases. A's in a younger individual, B's in a older individual. And so you can see how both hemoglobin and melanin contribute to skin color. Other things that can lead to hemoglobin contributing to your skin, there are 3 ways in which you can use hemoglobin in skin color as a diagnostic tissue. And so if you recall earlier, we were looking at thermoregulation. And you can see how when you get cold, the capillary beds shut off, conserve the blood flow back into the core of the body. That can eventually lead to frostbite if you have circulation cut off to your extremities for long enough. But then when you're hot, all these capillary beds open up to release heat to the surface, but that's what gives you this flushed experience. Same thing with a fever. This child's experiencing a fever. This is that typical bullseye rash, so an infection. So fever, infection, all these can lead to what we call erythemia. And so that is where you have more blood flow to the dermis. And then here is a inflammation around the lips that you can see the redness. So any type of inflammation, blood rushing to the skin surface, giving you that red flushed experience. Another is pallor. And so usually this is when you're deprived of oxygen. So when there is decreased blood flow in the dermis, like when you're cold here, and you get vasoconstriction. This is vasoconstriction, this is vasodilation. And you get a whitish color. And the collagen in the dermis is what starts showing through. And like I said, that's when you're trying to conserve heat in a cold environment, or can also when you're nervous and you get that flight or fright response. And we'll talk a lot about that when we get to the nervous system with our sympathetic nervous system. And the last of our skin colors as a diagnostic tool, so we've seen erythemia, pallor, and now we're going to look at cyanosis. And cyanosis is due to the amount of oxygen that the blood carries. And so when you get that bluish hue, that means that you get a deficiency in the oxygen that is being carried to the tissues. There's lots of diseases and hereditary defects that can cause this bluish hue in the skin. And so you can also, through lack of oxygen, but also this is a methahemoglobinemia. And so this is a common deficiency in a congenital defect, or it can also be through acquired things like just nitrates and nitrites in the soil. Some topical anesthetics will cause hemoglobin not to be able to carry oxygen anymore. And that will cause a bluish hue. And so here is an example of bluish fingertips from a disorder that causes the methahemoglobinemia. And there was this family called the Fugle family in Kentucky. And they were known as blue bloods. And here's a portrait depicting them. And here's one of the last living individuals. And they had a congenital methahemoglobinemia anemia. Here you can get acquired also, and the way you treat it is actually giving methyl blue, and that helps to enable the hemoglobin to carry the oxygen. And so here's before treatment, here's after treatment. Sorbic acid can also be used to treat it. And this is an individual who is just having low saturation, and you can see how her fingertips have also turned blue. So that is cyanosis. All right, so let's look at the accessory structures of the integumentary. So keep in mind that the integumentary biggest organ is the skin, but it also includes hair, nails, and glands. So the integumentary also includes hair, nails, and glands. And we've seen the hair embedded into the skin. The majority of the hair, the living part of the hair, is embedded in the dermis. Down here, that's your dermal root with the hair bulb. And so here's the hair bulb. Our actively mitotic cells are in this hair papillae. And same with the skin, as the cells move away from that hair bulb, they start to die. And that's why when you get your hair cut, or you shave your legs, or you shave your face, that cutting off that hair shaft doesn't hurt, because that's the dead part. And so you have the root, which is below skin level, the shaft, which is above skin level. The microscopic anatomy, we have melanocytes also in this basal layer of our hair. and this gives our hair color. And then the next layer is our cortex. The outer layer is the cuticle. The center layer is the medulla, and that's what you're going to see in all tissues, that the center of a tissue is a medullary region and the outer is the cortex, and sometimes it's surrounded by a cuticle. You can see the epithelial root sheath. This is our total hair follicle. Here is a photomicrograph of a hair. And with humans, hair is really too sparse to play too significant of a role in thermoregulation, whereas your dogs, cats, other mammals that are very hairy use it for thermoregulation. But it does provide us protection by preventing substances from getting in our eyes. So our eyebrows help to keep, sometimes, if you sweat too much, of course it's not, from dripping into your eyes. But also the nose hairs help with the mucus to catch particles coming into the nose, keeps our scalp from burning. So while we have hair on our head, it helps to protect us from both UV radiation and mechanical trauma. And also it's a sensory, because when we look at the hair again, not all the diagrams are showing it, but usually you have a neuron associated with the end of the hair, and that allows, when the hair is moved slightly, that you can feel the hair moving, and that tells you that something's brushing against you. So it's a sensory neuron with the hair that helps you to feel things. Throughout life, you have 3 types of hair. The first, when you're in utero, you have this lanugo, very thin, non-pigmented hair found covering entirely the entire body of a fetus. Usually falls out around birth and then is replaced with these 2 other types of hair. These are the shoulders of 2 twin girls, and you can see the lanugo on them. And you have terminal hairs and then vellus hairs. And so vellus hairs are what we have before puberty. And so these are a thinner, non-pigmented hair, and you can see how this is not pigmented. Thinner, non-pigmented hair all over the body. And then once you hit puberty and start making androgens, such as estrogen and testosterone, that vellus hair will convert into a terminal hair, a lot more in males than in females, because testosterone does it stronger than the estrogens. But females also get terminal hairs in the genital area and in the axillary region under the arms. And sometimes women get a little bit of facial hair also. And some women will have hairier arms than others. But the terminal hair is what replaces the vellus hair. And again, that happens at puberty when you start secreting androgens. And as I pointed out, the melanocytes in the hair follicle earlier, we have large ranges of hair color, just like we have large ranges of skin color. These are 8 typical hair colors, going from gray, and when it's gray or white like this, it means the melanocytes have stopped working, so there is no melanin deposit. And then our varying shades from blonde, brown, auburn to dark. And so blonde hair has little melanin, black has lots of melanin, and red actually has a I'm probably saying it, phytomelanins in it, which is a melanin pigment that has an iron associated with it, and that gives the red color. You can also find those phytomelanins in skin. They're particularly concentrated around our lips, nipples, glands, the penis and the vagina, those areas that we have a reddish hue to our skin. So the same pigment that gives us our red hair gives us that reddish pigment in our skin. As we get older, they are less active, and so that's why a lot of people do go gray or white, because the melanocytes aren't depositing melanin in the hair anymore. Our nails. So this is a typical tip of a finger. So this is our fingertip. This is the phalange, the bone in the finger, surrounded by adipose with the nail overlying. So the nail is there to protect the digits, to help keep your fingers protected. And so it grows from the matrix. And so this area back here, this nail matrix, is where your where your nail grows from. And you can add about a 1/2 millimeter per week in nail growth. Your toenails grow a little slower. And as the nail grows out, it's cut off from its blood supply, just like we saw with the hair and the skin. And so the exposed nail is dead. And so you have the free nail edge is what we see. The primary function, again, is for protection from trauma. And then it can also be used as a tool. So you can let it grow longer and use it as a little bit of a screwdriver or something to scrape things off with. The last structure of our integumentary is the glands. And so our skin contains glands. The two main types of glands are sweat glands and our sebaceous glands. So sweat glands, we have two types of sweat glands, but we have two other modified sweat glands, the ones that make earwax and milk. These are also called sediferous glands. Our sebaceous glands produce an oily sebum, which is a lot thicker and contains cell debris. We're going to look at this in more detail coming up. Okay, the first gland that we're going to look at is going to be the Accessory sweat gland. And this is a gland that deposits its secretions directly on the skin surface. So you can see this in our skin models, and here in this diagram, it's a gland that deposits its secretions right on the skin surface. It's our most prevalent type of gland. It also undergoes a type of secretion called Murekin secretion. And so Murekin secretion is where the cell makes the substance and then releases it via exocytosis. The cell remains intact and is healthy and continues to secrete that Murekin secretion and then stays healthy. But it's a simple coiled tubular gland, mostly containing water, waste products, and electrolytes, and again, exits right onto the epidermal surface. An apocrine sweat gland is slightly different in that it empties into a hair follicle. And so here is an apocrine sweat gland. You have that same coiled structure, but see, it empties directly into a hair follicle. So it releases its secretions into a hair follicle. So you're going to find the apocrine sweat glands more under your arms, somewhere like that, where you get sweat associated with the hair follicles that are under the arms. So the axillary, the anal region, the genital region around the chest, the areola. And these are large glands, release a more protein-rich secretion into the hair follicle. So it has some more things that bacteria like to feed on because it's protein-rich. And that's what gives us our smell. That's why your underarms stink, is because the bacteria that live in those areas or in the groin area metabolize that protein-rich secretion from our apocrine glands and degrade it, giving off an odoriferous smell. Get a lot more of the apocrine secretions once puberty hits, so the sex hormones will really increase the secretions with those. And so also, as I mentioned earlier, we have two other types of glands. So we have the Accessory and the apocrine sweat glands, and then we have the cremaceous glands. These make earwax. And so that earwax binds to the hairs in your ear and helps to catch particles coming into the ear canal. Your mammary glands, very active when you are reproducing, and so they produce milk in the alveoli of the mammary glands, and so they are a modified sweat gland just like our cremaceous glands. So our four types of sweat glands are our Accessory, apocrine, cremaceous, and mammary. Our two main types of glands are the sweat glands and the sebaceous glands. And the sebaceous glands are oil glands. And so they are surrounded by acini. Cells called acini surround the small ducts, converge into central ducts, and secrete something called sebum. So it's a very oily secretion. Found everywhere except the palms of the hands and the soles of the feet. So they are associated with a hair follicle. And so you don't have hairs on that thick skin. Remember, thick skin does not have hair, and that's the palms and soles. Found a lot on the face and the scalp. And when they get inflamed, that's when you get acne. And so, as shown before, sex hormones really increase secretions from our glands with the apocrine and now with the sebaceous. And that sebum occurs after puberty. And so here's what the sebum glands look like. So this was our Esseren sweat gland, emptying directly onto the skin surface. This is our apocrine gland, emptying into a hair follicle. And the sebaceous glands are these globular type glands associated with our hair follicles. And remember, I pointed out the mercrine secretions that did not harm the cells. Earlier, with the sebaceous gland, you actually get halocrine secretions, and this causes the whole cell to rupture, and so the cell dies. So these secretions are from dying cells, and so there's a lot more cell debris. So you got cellular fragments and debris in addition to the lipids and the proteins in the sebum. Helps to moisturize the skin, provide a hydrophobic barrier, inhibits water, also inhibits growth or kills certain bacteria. But as mentioned before, with the pathology of the skin, we can also develop infections of those sebaceous glands. And when we get an inflammation of our sebaceous glands, we get acne. Acne vulgaris affects 96% of all adolescents. It is caused by accumulation of that sebum in our sebaceous glands. And when it produces condom, that is a blackhead. So here's an example of a normally functioning sebaceous gland. This is when we get a whitehead. We start getting an infection in there. And then this is where it ends up converting into a condom, a blackhead, and it plugs the entrance to the pore. And then that inflammation can also be severe, and that's where we get acne, cause permanent scarring. And the testosterone seems to cause it more strongly than estrogens, and so you see it more in males, especially when entering puberty, and usually disappears around the age of 20 to 25 when the body levels off. There are several different types of wounds in skin pathology. Lacerations or cuts. We have burns, and we have skin cancers. So the degree of the burn tells you how deep the burn is. So first degree burns are just superficial, only affect the epidermis, like a sunburn. Minor and usually will resolve itself. And so you get that erythema, that red appearance that we talked about earlier, and you may have some mild pain but no permanent damage. Second degree burns affect part of the dermis, not the entire thickness of the dermis, just part of the dermis. And this is where you'll also start getting some blistering. A lot more pain and sometimes some scarring, and you can get a severe enough sunburn that it would be classified as a second degree burn. So it's a partial thickness, not the entire thickness of the dermis. And our third degree burns go all the way through. And third degree burns at first don't hurt that much because you've gone all the way through. You've actually destroyed all of those sensory receptors in the dermis. And so they don't feel that painful at first. But after a little while, they sure do. And it also opens you up to lots of issues such as infections, dehydration, because the skin protects you. It's your barrier to the outside environment. It also keeps things in your body, such as fluids. So once you get a third degree burn, depending on how severe it is, it can really open you up to infections and dehydration. And so that's what this slide is talking about, opening up to infection and dehydration. The way burns are classified is the 9s rule. So to quickly assess and assign a percentage of burn, the extent of burn. So each front of leg is 9%, each back of leg is 9%, back body, front body. but it's the rule of nines, and they quickly assign this percent of burn to a burn victim when bringing them for assessment. And so that way everybody kind of has the same percentages in their head when assessing burns. Where skin model also shows first degree burn, partial thickness with our second degree burn, and then complete destruction with our third degree burns. So you can see that on the back of the larger skin model in lab. The last of our skin is cancer. So skin cancer is a big problem in America. Unchecked cell division is what cancer is. If you recall back when we were talking about mitosis in chapter 3, and how when you lose that checkpoint that you get uncontrolled cell growth, and then that results in a tumor, and when you lose that adherence, it metastasizes and spreads. Most skin cancers are not deadly, but the malignant melanoma can be, because it metastasizes and moves around the body. And as long as you catch things early, they are very curable. They can be caused by carcinogens or radiation exposure to the sun. And that's why you tend to see a lot of the cancers on the head and face. So our most common of all skin types is our basal cell carcinoma, and that tells you where it affects. It affects in that basal layer. Remember the basal layer of the epidermis. And it's usually because of regular exposure to UV radiation, has a nodule and a central crater, and usually can be resolved with just surgical excision. Squamous cell carcinoma is going to be in the squamous cell, the stratum spinosum. And so you'll find it down in the stratum spinosum. Second most common type of cancer. Get some ulceration with this. Usually scaly plaques, ulcerated bleed found on the head and neck. Tumors are more likely to metastasize than basal cell, but usually they can easily be removed surgically as long as you catch them early enough. So don't ignore things like this, especially on your older individuals. Now, malignant melanoma. This is a cancer of our melanocytes. That's the guy that makes the pigments. And so early detection is really critical. A lot of the melanocytes, remember how those arms of the melanocyte go up into the other layers and actually can touch and get down into the dermis, where they come in contact with the circulatory system, and then there they spread. That's how it spreads, is with the circulatory system. So our melanocytes have those arms, and if you catch it early enough, usually treated surgically, possibly other options such as radiation, and immunotherapy is what really works well with the malignant melanomas. And so prognosis really dependent on how early it's caught, the size, and whether it's metastasized. You can determine the extent of a malignant melanoma with the ABCD rule and E. And here is an example. So this is a melanoma, and this is a normal mole. So look for asymmetry, so irregular borders. So two sides don't match. Irregularity. And so here is a melanoma with a lot of irregularity, and also the coloration. All of these, you can see the different coloration in the melanomas. These are your typical normal moles that you don't have to worry about. And then a diameter greater than 6 millimeters, which is about the size of a pencil eraser. And then evolving, that it changes all the time. Those are the ABCDs of looking at a malignant melanoma. All right, well, that ends our Integumentary. I appreciate your attention, and let me know if you have any questions. Have a great day.